Thank you. Can you hear me? Can you hear me?
Yes, we can hear you.
Oh, perfect. Let me increase my volume. Right, I'll share my PowerPoint presentation. I know that you guys are running a bit late, so good afternoon from my end and good evening from your end from the cold north of England. I think it's about 1 degree centigrade. It says the host disabled participant screen sharing. So if you can get that going, I'd like to thank Dr. Shekhar, Piyush, and the team for giving me an opportunity to speak at this meeting. I will try again to share. I'm still disabled from the point of view of sharing, but let me try again. Yeah, that's great. So thank you for the opportunity. I think it is the right controversy because we're asking ourselves the question: has Basel III trials muddied the waters? The point is this: the Basel III trial has not been published, so this talk is going to be a bit philosophical and a bit on documentation and a bit on evidence. We are a very high recruiter for Basel. In fact, for the Basel II trial, we were the second largest recruiter in the trial. And we put in about 8% of patients into the Basel III trial. These are my disclosures. These disclosures do not have any effect on the present talk. As you can see, I come from the northeast of England, a place called Hull. Can you see my screens?
Yes, we can.
I think you can. So comes from Hull, and we cover quite a large area, large population, and Dr. Piyush Jain used to work with us, and he knows the kind of work that we end up doing. Hull has problems. That's why we are large recruiters. There is smoking, there is obesity, there's low socioeconomic state in the UK, and there's everything that's kind of a milieu for peripheral arterial disease. But Hull is also UK Sydney, for those of you who are willing to come. We have a nice bridge. We have the Deep that looks like the Opera House, and we have nice stadiums. So people who are wanting to come and work with us, don't get put off by the previous slide. We have a nice big hospital, and on the second floor of that hospital and third floor of the hospital, we do most of our work. Now, I'm going to be a bit cheeky and take you through a very interesting trial called the Random Stop Study. So what they did was the aim was to assess the proportion of patients undergoing endovascular therapy for FEMPOP disease who are eligible to be taken part in major trials. What would have happened is all of you will be talking about a huge number of trials about drug elution. Now, how many of our patients actually would fit that trial to look at that evidence? What studies tend to do is they enroll highly selected patients, and outcomes may not be fully applicable to your daily practice. Now, let's look at this. 16 centers were taken, and 1,600 patients were enrolled. And these were the trials, and I'm sure from the morning you've been hearing all these trials: Impact SFA, Levant 1, and all the other trials, 𝐧𝐿VA PTX, etc. So what I want you to do is, if you can scan this QR code and tell me what percentage of patients would be suitable to include in all these 7 studies. Now, you can even go to slido.com and just enter that. You don't have to register or anything like that. If you enter that hashtag, you will be able to. So give me a number. Now, what they did to give you a backup is that they took 1,600 patients, and then they put in how many of all these patients would go into all 7 studies. So I just put in 30, somebody has put in 10%, somebody's put in 20%, somebody's put in 60%. So as there's a weightage. So basically, let's take an average and say Okay, about 25% of patients would go in to all these studies, 7 studies, okay? Here's the verdict. The number of patients who would go into one study is 15%. And the number of patients who would go into 7 studies is 0.13%. So what we are doing here is we are sitting in various places in the world and quoting evidence from Impact SFA, Levant 1 and 2, Illuminate, Ranger, Eminent, Imperial, Silver PTX, and we are thinking we will take this evidence and put it into our daily practice. But actually, when you took 1,600 patients who all comers who came in and put the inclusion-exclusion criteria, only 0.13% of these patients actually fitted in. Then how can you take this evidence and deliver it to the 99% of patients that we're treating? Isn't that a very interesting comment to make? So we can discuss this when we come to the end of the talk. Now, what about Basel III? Basel III, what it did was, is the use of drug-coated balloon or drug-eluting stents clinically and cost-effective in endovascular treatment? That was the question, of course, in critical limb ischemia. That was the question that was being asked. So what was being done was patients with SLI's severe limb ischemia, or CLTI, you can call it now, patients were recruited who were suitable for endovascular repair into 3 groups. So once the patient was suitable, a research nurse used to discuss the trial with the patient, get an informed consent, and then completes a baseline assessment form and randomizes the patient. So inclusion criteria were CLTI due to FEMPOP disease. They were put through an MDT, which included vascular surgeons and IRs working within an MDT environment to say, yes, this patient should be suitable for endovascular repair, and then adequate inflow and FEMPOP plus minus infrapopliteal involvement, and then they were put into 3 groups. So what were the 3 groups? Plain balloon angioplasty, POBA. I know our good friend Sunil Rajendran is going to speak about POBA after me. DCB, both in these groups with POBA and DCB, if there's a dissection and you want to stent, you need to put a plain bare metal stent, and then drug-eluting stent as a final thing. And what they did was 2 things: economic analysis and then major amputation or death. Those were the 2 things that were looked at. So compare this to Basel II randomization, 300 patients, vein bypass first versus best endovascular treatment. Basel III randomization, this was what was started. This was picked up from Professor Badbury's talk in 2015, where they were looking at randomizing 287 patients into each of these 3 arms. The key thing that I want you to remember is 846 patients, 287 patients POBA, 287 patients bare metal stents, and 287 patients drug-eluting stents. Follow-up for a minimum of 24 months, a maximum of 60 months or 5 years. So this was the grand plan when Basel III was started. Now this was, I told you we put in about 8% of patients into this trial. This was one of the patients. You can see FEMPOP disease, adductor disease. What we have done is this patient went through randomization, drug-coated, which was an Eluvia 6mm stent that we put in and treated those segments. So this was what we were doing in that point. Now, what was the primary endpoint? The primary endpoint was amputation-free survival. And this is defined as the time to major limb above ankle amputation, that is below knee or above knee, amputation to the index trial limb, or death from any cause. Now, this is a very important point, that take-home point that you need to have. So death from any cause, amputation-free survival. What I'm interested in, and there are a lot of secondary endpoints that were looked at, what is the most interesting and probably something that we will discuss at the end is the re-entry and crossover intervention rates. That is an interesting topic. Now, when you look at the impact SFA 3 years outcome, primary patency, for the DCB was around 70%, whereas for just POBA was around 45%. And when you come at freedom from clinically driven target lesion revascularization, once again, the drug-coated balloon did much better than plain balloon angioplasty. And this is something that is seen through multiple trials. And this, obviously, many people will be coming to you and talking about each of these trials. But the key thing I want you to remember from this slide is most of these trials look at freedom from target lesion revascularization. And that's around 1 or 2 years' time. Now, another key problem that we need to remember is that many of the patients that we do an angioplasty sometimes come back. And that's around 4 to 6% of patients who have had an angioplasty tend to recur for recurrent treatment. And the question is, could you spot them and could you use newer technology in order to stop that from happening? So this background of plan for Basel III brings me to my topic, Basel III trial insights, has it muddied the waters? So is the Basel III data published? The answer to this question is no. The data is not published. So what I did was I emailed one of the people who was a prominent trial coordinator and asked him, said, look, somebody from Mumbai has called me for giving this talk. Can you give me some data? So this was the email cut up. Currently, Basel III headline manuscript is in the journal, not yet accepted, lots of round of reviews. I really can't share anything until it's published. Now, this is a problem because what happened was, why has it taken so long for the results to be published? In fact, Professor Bradbury, who was the chief investigator, presented the results early this year at Charing Cross. And various presenters have picked up from these early results. So there have been result leaks, if I can put it that way, almost in a political kind of sense. There's been leaks. And that is why Dr. Shekhar has nicely asked the question, has it muddied the water? So what is it that we know? So this was the question that Basel III was asking. Is plain balloon angioplasty, bare metal stent, and DCB and drug-eluting stent, is it similar in effectiveness to drug-coated? And the answer is probably yes. So amputation-free survival, the primary endpoint of the trial was amputation-free survival. After a 7-year follow-up, amputation-free survival was 34% in the POBA arm, 40% in the DCB arm, and 42% in the DES arm. So not a huge difference between the 3 arms. Clinical benefit. Once again, they said the trial did not find that DCB or DES offered a significant clinical benefit compared to POBA. What do we mean by clinical benefit? The point is, you have a patient who comes with CLTI, either rest pain or ulcers. You do a procedure, and then clinically the patient benefits from it. Whether the vessel is patent or not, who is bothered? Because from a patient's point of view, it is my father, who's 83, and he has critical limb ischemia. Then what will happen is his ulcers have healed. He's going around. He goes and gets his newspaper. He reads his newspaper. He's happy. So what's the point? Why do you go around checking, is this patent or not patent? Who cares? And then cost effectiveness. The economic analysis found that the cost effectiveness of all 3 interventions varied based on patient level data. In fact, they found it was more expensive. And I don't need to tell the Indian audience, obviously it's more expensive to use drug-coated technology compared to plain on balloon. So teasing the results out a bit more, between January 2006 and August 2021, 481 patients were enrolled. If you remember, when I started off, I said in 2015, the plan was to enroll 800 odd patients. But now that dropped down to 481 patients. And why? Because COVID was involved in the process. And also there was a Katsonis pause that we can talk about. And then they looked at amputation-free survival. They didn't just look at amputation related to CLTI. They looked at amputation-free survival. So the intention to treat analysis 34% for POBA, 40% for DCB, and 42% for DES. And actually, when you look at per protocol analysis, it is even closer, 35, 39, and 40, right? So there are some questions. In fact, when I was at the VSI conference in Jaipur, somebody said, oh, the trial was not powered sufficiently. No, the trial was powered reasonably well, because what was required was more than 291 primary outcomes. And so the trial power exceeds 90%. So the trial was definitely powered. The Katsonis pause of 2018 affected recruitment. What happened is, most of you are aware, Costas came out and published that paper where there was a signal of mortality in paclitaxel. Then what happened was people stopped using paclitaxel. There was a lot of discussion, and we had major organizations in the country saying you have to consent patients for a signal of death due to it. So people stopped using it, and that was a major problem that affected recruitment. The next question which we need to discuss: has the power calculation taken into account the role of death versus limb outcomes? Because we are interested in limb outcomes and not necessarily death. Of course, patients are interested in death. And the problem is death due to COVID, because nobody knows whether the patient had a successful angioplasty, had the limb, but died because of some other cause. For example, COVID, because this particular trial went through that particular time. The other thing that has evolved over that time is vessel prep. Now, we tend to do a lot of vessel prep before we do drug-coated technology, be it drug-eluting stent or drug-coated balloon. Vessel prep was not a major practice at that time. So what are the take-home points? The findings cannot be taken in isolation. So I would say, if you ask me, look, based on these, and you say you're a top recruiter, what are you going to tell us? I wouldn't take the findings on isolation, but I would also not take the findings to say the drug-coated technology is the be-all and end-all of keeping a vessel patent and taking it forward. So what I would do is, the cost of DCB and DES is a concern. I would take it into consideration. I would probably use it in task 3 or 4 lesions when it comes to drug-coated technology, because these are long lesions. The patients are probably not suitable for a vein bypass. And when you treat long lesions, we know that the success of patency is low. I would use it in calcific lesions, of course, after calcium modification with some kind of atherectomy or intravascular lithotripsy or something like that. I would use it in re-interventions, because these are patients who are coming back with a significant amount of aggressive disease, in which you would want to use this particular technology. And the role of sirolimus is evolving. You would have noticed that there are a couple of Japanese studies that have come out which are showing really good outcomes. And I know that Eddie Choke is giving a talk tomorrow morning, and I'm sure that he will talk about the sirolimus and concept balloon. So with that, what I would do is I would ask you to put some questions on. You can similarly use the same slido.com, and I can also take questions from the flow. But if you're not happy to talk out and you just want to type out a question, it'll be easy. This will come onto it and I can pick it up. And thank you enormously for having me for the talk, and thank you for listening to me today.